Good morning, everybody. This is Shannon Finks with the Finks 5. This is where we talk about a therapeutic area in 5 to 15 minutes. And sometimes my students do these as a part of their clinical training, but today this one is for my students. And you will be coming to ZüpMed, and we will have patients enrolled in our Cardiometabolic Risk program. And I want you to understand exactly what we're doing. So you're going to see patients, and I'm going to ask you, well, what is their ASCVD risk? And you know that all of you should have downloaded on your phone your ASCVD calculator. And this particular calculator is what's recommended by the ACC, the American College of Cardiology, as a means to estimate both 10-year and lifetime risk for having some type of heart event or stroke. When I ask you to estimate someone's ASCVD risk, though, you have to know what is included and what's not included so that you can make a proper risk assessment. And after you've done a few of these calculations, you'll understand very quickly what's included, and that is a patient's age, whether they're male or female, their race, their systolic and diastolic blood pressure, total cholesterol, HDL, LDL, whether or not they have been diagnosed as diabetes, and whether or not they're a current or a former smoker, and what medications they may be receiving for blood pressure, if they're on a statin or aspirin. But what is more important to consider is what that calculation is not accounting for. So if you're talking with your patient and you understand that they have a family history of premature ASCVD, that calculation that you just performed is going to be underestimated. That calculation does not include social stressors like depression or even stress that we know can increase risk for cardiovascular event. It does not include inflammatory markers or inflammatory conditions. And so HSCRP, high sensitivity CRP, is something that we'll be looking for. We also may account for inflammatory diseases like autoimmune disease or rheumatoid or even HIV as a risk factor because that is not included in the calculation. The ASCVD calculator does not include weight or BMI, and we know that this is an inflammatory condition as well as a condition that is metabolically important, and you will understand very quickly as we take care of patients in our cardiometabolic risk program that they may come to us concerned about their weight, but there are so many other cardiometabolic risk factors that we will improve with weight loss and addressing these other risk factors simultaneously. Insulin resistance goes along right with that. This calculator accounts for diabetes status, but what about prediabetes? What about someone who we can reverse their risk by weight loss or other means using medications to reverse this insulin resistance piece early rather than waiting until someone develops an irreversible damage to their pancreatic beta cells. Chronic kidney disease, where they're from, what geographic region is not included in the ASCVD calculator, and these are very important to consider. When people come to us for the cardiometabolic risk program, many of them are coming for weight loss. However, there are a lot of other considerations that we as their healthcare provider need to address. And number one, in addressing cardiometabolic risk, we have to determine their ASCVD score, and we have to look at that atheroma burden or that cholesterol burden. So this is when you're going to calculate your ASCVD score, you're going to think about statin benefiting groups, and you're going to start or modify statin plus or minus other cholesterol medication therapies during that time according to evidence-based treatment guidelines. Another piece is that underlying inflammation really drives cardiometabolic risk. This is an inflammatory disease as well as it is a disease that has a cholesterol component to it. And so we're going to address both simultaneously. But what's kind of in the middle and the biggest piece of this picture, in my opinion, is the insulin resistance. And you are going to evaluate glucose and A1C and looking for measurements such as waist circumference or even triglycerides and that burden, because this is the piece that will address weight loss. And this is also the piece that I think is the missing link in our understanding of obesity. Obesity is the fifth leading cause of death in the world, and in the United States, we've seen an increase from about 30%, a third of patients being obese, to now 42.4%. And childhood obesity affects a third of all children under 20. This is staggering, and this is driving our disease process, not only for cardiovascular disease, but other metabolic diseases, cancer, and disability in the United States today. And so when we talk about treating overweight or obesity, overweight is defined as a body mass index of greater than 25 kilograms per meter squared, and obesity is a BMI greater than 30. And there are limitations with using BMI alone, and we may dig deeper into that concept as in another Finks 5. The point that I want you to understand very significantly is that we have an opportunity to prevent and to reverse insulin resistance and obesity before someone has long-term damage, before they develop prediabetes and diabetes and then heart disease and heart failure and chronic kidney disease and all of these drivers of the billions of dollars that we spend in our healthcare system. People want to understand, and people want a solution for their weight, and we can start with that and make our patients healthier. Metabolic syndrome is a complex syndrome, and it is one that you have to have 3 of the 5 criteria in order to be diagnosed as metabolic syndrome, and these are parameters that we will assess in our cardiometabolic risk program. So we will get a waist circumference in everyone at baseline and at 12 weeks and at 24 weeks. Every 3 months, we're monitoring their progress. If a patient presents with high fasting triglycerides, that's a sign of insulin resistance. If their HDL is low, if their blood pressure is elevated, if their glucose is elevated. So meeting 3 of these 5 is a rationale for us to be aggressive early on so that we prevent prediabetes, diabetes, cardiovascular disease. And so I want you to be very familiar with this definition, and as you assess your patient, this may be a rationale for us using certain pharmacotherapy to reduce their risk. Just want to talk a brief second about waist circumference. There were many practitioners who believe that waist circumference should always be a vital sign. Not a lot of physician offices do measure waist circumference. We do, and this is an independent risk factor for lots of cardiometabolic diseases. And we're searching for, we want a waist circumference of less than 40 inches in men and less than 35 inches in females. And in certain ethnic groups or racial groups like Asian Americans, that waist circumference goal may be smaller. And you can look at the guidelines to figure out which ethnic group matches. But as a general rule, it's 35 inches in females and 40 inches in males. And as you can see in the picture, this waist circumference is not at the smallest part of the waist. This is actually measured at the belly button line almost. It is, you take the middle between the top of the iliac crest and the lowest palpable rib, and in between that mark is where your waist circumference lies. In terms of inflammatory disease processes, we're going to draw an HSCRP at baseline, and we may also draw a homocysteine. These are inflammatory markers. It gives us an objective assessment. And then also, you may, in talking with your patient, have inflammatory diseases that are in their past medical history that may contribute to their underlying process, their underlying inflammation. Finally, I just want to summarize that cardiometabolic risk is not just an ASCVD score. There are many pieces to this puzzle, and this is complex, and we are going to take this opportunity to provide success with weight loss and other reductions in cardiometabolic risk. And this is something that needs to be personalized with each patient because each patient has different unique risks. And we're going to address those risks at baseline, and we'll be talking with patients every week as they go through our program. But we'll draw those objective measurements of labs every 12 weeks within our program. So that's it. That's a high-level discussion of cardiometabolic risk and our program and why we look at the things that we do. If you're my student on rotation, or if you're a potential patient that accidentally found this post, we welcome any questions that you may have. You can call us at ZüpMed at 901-701-7010.